So congenital diaphragmatic hernia is actually one of the conditions that still continues to perplex surgeons, obstetricians and neonatologists. Because it's one of those conditions where there's an anomaly in the fetus that the diaphragm, which is the muscle that separates the chest from the abdomen, doesn't completely form. So a hole develops in the diaphragm, and through that hole, organs within the abdomen can pass into the chest. What really results with diaphragmatic hernia is that the lungs also do not develop as well. Either it's because the organs are there or because whatever didn't allow the diaphragm to develop also didn't allow the lungs to develop. But typically what we see is that the lungs in those children are typically small, much smaller on the side where the defect is, but even the other side also tends to be quite small. So the problems these children have down the road is not so much so the hole in the diaphragm, but the fact that the lungs do not develop very well.
Well, for infants with diaphragmatic hernia, there's a spectrum of severity, and there are infants that are very mildly affected, and the amount of pulmonary hypoplasia that they have at birth is relatively minor. And there are rare infants that we don't even pick it up after they're born. We pick it up when they're older, when they're months old or a year old, or even incredibly rarely when they're in childhood. But most infants with diaphragmatic hernia, we pick it up immediately after birth, and they're very severely affected. And they present a problem in the management due to their lungs not being developed properly. Fetuses that might benefit from a procedure like we did today, the fetoscopic endotracheal occlusion, are those with the most severe forms of the disease. We don't do this procedure for those fetuses with the mild forms. We are not doing it for those with the intermediate or moderate forms. We're only doing it for those with the most severe form of diaphragmatic hernia. And those are babies that we would predict are likely to die from this condition after birth if they don't have this treatment.
So diaphragmatic hernia is typically diagnosed essentially by the time the first ultrasound is done most of the time. The ultrasound technology now has gotten very good, that from about 18 to 20 weeks when most women will get their initial anatomy survey, a severe diaphragmatic hernia may be diagnosed at that time. Some that are not so severe may not even be quite obvious yet and may be picked up later on in the pregnancy, but we can see very many of them as early as about 18 to 20 weeks of pregnancy. All right, so most patients with diaphragmatic hernia are still best treated after the baby is born, and we'll treat the baby after birth, and with the expertise of a neonatologist, really support the ventilatory status, support the lungs, support the baby in general, and get them through limping along with the lungs that are not fully developed until the lung can catch up in development. We'll do the surgery to fix the defect, bring everything down, and allow the baby to recover. However, we found that there's a subset of patients with diaphragmatic hernia that are so severe that in spite of our best efforts, and even with all the technology available to us, be it ECMO or high frequency ventilation, nitric oxide, we still have very poor outcomes in those babies. So that subselect group are those that we figured there must be a better way to do this. The problem really is to get the lungs to grow. We're hoping the lungs can grow after the baby is born, but what if we can get the lungs to grow before birth? And that's really where the initial research was done, to see different modalities by which we can get the lung to grow before birth and intervene in utero.
Well, the fetal center at Texas Children's Hospital is absolutely amazing. I mean, we're sitting in one of the operating rooms at this facility, and it's very clear that the technology available, the expertise available, and the experience at Texas Children's Fetal Center is world class. It is such a privilege for me to be part of a team that has so many multidisciplinary participants. We have pediatric surgery, Dr. Olatoya and Dr. Cass. We have pediatric cardiology, Nancy Ayers and Carrie Altman and Shane Morris, and we have every single pediatric subspecialist you could wish for right here in the fetal center. So we are quite uniquely positioned to do and to offer this kind of surgery amongst the many other fetal procedures that we offer. This baby has a left-sided diaphragmatic hernia with the liver up. That means that the liver is in the chest, and a lung-head ratio of 0.9, which by the classification system is a severe diaphragmatic hernia. So this is not a good situation for this baby, and it justified the placement of a tracheal balloon, which is the procedure that we performed.
So the procedure we did today actually was a case of fetal endoscopic tracheal occlusion, where we put a balloon into the fetus to plug the trachea. Now we're doing that because we've found out from animal work and a lot of work that's been done several years before, that really if the lung continues to make fluid all through pregnancy, that fluid comes out from the lungs into the amniotic fluid. Now, if you actually occlude the trachea so that the fluid doesn't come out, you can actually get the lungs to grow bigger and bigger. So the thought therefore was, in these children with diaphragmatic hernia, or these fetuses with diaphragmatic hernia, if we could obstruct that trachea and get the fluid to accumulate and cause the lungs to grow, then we may actually be able to improve the size of the lungs. So we're able to go in and place a balloon into the fetus, right through the mouth, through the vocal cords, into the trachea, and blow up that balloon and detach the balloon, leaving it in position.
And what that balloon is going to do is block the exit of fluid that the lungs make during the fetal development. And the fluid will be blocked up like a dam, and as a result of that damming effect, the lungs will gradually inflate and will induce growth, and provides an opportunity for these lungs, which are very small right now, to get bigger. And the hope is then when the fetus and baby are born that they'll be able to have better lung function than they would have had without the treatment.
This is the first stage of the procedure. The balloon is left in place for the lungs to now grow and inflate over the next several weeks, and then we'll come back about 5 to 7 weeks later to now remove the balloon after the lung has had appropriate time to grow. This is still an experimental procedure. It requires approval by the Institutional Board of Baylor College of Medicine, and also we're one of the few centers in the United States that has approval by the Food and Drug Administration to perform this procedure. The procedure today went quite well. It was a little technically challenging, as these cases tend to be, but then again, that's why you have a team of experts that are very good at what they do, and with all the heads together, we're able to persevere and get it done. The balloon was placed in a perfect position below the vocal cords in the trachea. We're able to confirm the position. The baby did great through the operation. Mom had excellent anesthesia. Baby had excellent anesthesia. Mom and baby are comfortable in the labor and delivery service. But the real work really just starts. The balloon is in place. There's still a long way to go. We're quite hopeful and excited as to how the day has gone so far.
What's in store for Mom from now on is initially we hope that she doesn't go into preterm labor. Whenever you do these kind of procedures, there is a risk of preterm labor and loss of the pregnancy. The next risk is approximately a 30% risk of rupture of the membranes. So that may occur. This mother will stay in Houston, very close to our hospital, until she delivers, because we cannot take the chance that she may deliver at a facility where they cannot remove that balloon emergently. So if she goes into unscheduled, or she goes into labor and the balloon is still in place, that is an absolute emergency. She would come in and we would perform something called an exit procedure, whereby we deliver part of the baby, the head and the neck, and then we go in and remove the balloon while the baby is still receiving blood from the placenta. And once the balloon is out and the baby's airway is secured, then we deliver the rest of the baby. So she'll be in Houston until this CDH is repaired.
But we're hopeful that with the procedure today, that this fetus will have the very best chance of pulling through this very difficult condition and disease.